The year was 1944. Western Europe was burning. This U.S. Army field hospital had been erected in under 72 hours. Canvas walls, steel frames, generators pulled from the mud. It sat near a shattered transport route used to move prisoners and wounded civilians alike. The woman on the table was in her early 30s, captured weeks earlier, transported after collapsing during interrogation. Initial triage notes were brief: severe abdominal trauma, signs of internal hemorrhage, septic shock already setting in. Doctors had seen this before, and they knew how it ended. In the 1940s, abdominal surgery was a gamble even under ideal conditions. Infection rates exceeded 30%. Blood transfusions were limited. Antibiotics like penicillin were scarce and reserved for soldiers. POWs were not a priority. Outside the tent, wind carried smoke and ash from burning villages. The sky had turned a dull, bruised orange, not from sunset, but from fires still raging across the hills. Inside, instruments were laid out on metal trays. Ether masks prepared. A single generator powered everything. Nurses whispered. Surgeons studied the woman's vitals. Her pulse was erratic. Blood pressure collapsing. Something was wrong, deeply wrong. And then came the early warning signs. Her abdomen was rigid, distended, a symptom known as peritonitis, the body's equivalent of pressure building beneath a volcano surface. Doctors exchanged looks. They had seen trauma. They had seen rupture. But this felt different. One surgeon later recalled. It was like the body was holding back something violent, something waiting. What came next shocked everyone. At 15:42 hours, the monitors spiked. Her heart rate surged past 160 beats per minute. Respiration became shallow. Skin temperature dropped. A biological tremor. As surgeons opened the abdominal cavity, pressure released instantly a rush of fluid, blood, and infection spilling outward. This was no single injury. This was a cascade failure. The intestine had ruptured in multiple places. The liver showed tearing consistent with blunt force trauma. The abdominal cavity was flooded with bacteria. In geological terms, this was a system breach like magma forcing through fractures no one knew existed. The surgical team froze. No protocol covered this. No training manual prepared them for a body this close to total collapse. Every 10 seconds, her vitals destabilized further. They were no longer racing the war outside. They were racing biology itself. Then the generator coughed. Lights dimmed. 5 seconds, 5 eternal seconds, the operating tent went nearly dark. Rescue teams froze. Scalpels hovered mid-air. Outside, another explosion shook the ground. Inside, nurses manually pumped oxygen. Blood transfusions were rationed drop by drop. Residents had only minutes to react because once septic, shock reaches a certain threshold. Survival time collapses exponentially. Data was being misread. This was a runaway biological eruption, and the body was losing. The surgeons argued quietly, urgently. One insisted they stop. She will not survive closure. Another disagreed. If we stop now, she's already dead. There was no consensus. Medical theory at the time said prolonged abdominal exposure increased mortality. 8 hours of surgery was unthinkable. No model had predicted this scenario. This changed everything. What they were seeing suggested something deeper: trauma, compounded by untreated infection, starvation, and systemic shock. A perfect storm. A hidden pressure pocket that had gone undetected until it was too late. And yet against every statistical projection, the patient was still alive. Barely. At hour 5, something extraordinary happened. Her vitals stabilized. Not improved. Not recovered. But stabilized. It was as if the body, having released its internal pressure, had entered a fragile equilibrium. The surgeons pressed on. Resections. Sutures. Drainage. Every 10 seconds mattered. By hour 8, the operation ended. The tent was silent. No celebration. No certainty. Only exhaustion. Because survival didn't mean safety. It meant waiting to see if the eruption would return. Over the next 72 hours, the camp watched. Fever rose. Then fell. Infection threatened, then retreated. Against every expectation, the German POW lived. Airports nearby were closed due to ongoing fighting. Villages remained evacuated. Relief efforts continued outside the tent. Inside, a single patient rewrote what wartime medicine believed was possible. She would later be transferred, then released. Her name faded from records, but the case did not. That night, a surgeon wrote in his journal, "We were certain we were witnessing the end. Instead, we witnessed a beginning." The war would rage on. Bodies would break again. But something had changed. Because even in the chaos when every model fails, life sometimes does the unthinkable. And somewhere, in the silence after the alarms, scientists are still watching.